And we're pivoting now to hear from free and referral clinics. And we have with us Dan Barlow and Olivia Sharrow. So thank you and welcome.
Thank you. For the record, Dan Barlow, Executive Director of the People's Health and Wellness Clinic.
And for the record, Olivia Sharrow, Executive Director of Vermont's Free and Referral Clinics.
And Olivia,
should I take it away?
Yeah, please.
All right. So as I just said, I'm Olivia Sharrow. I'm the Executive Director of Vermont's Free and Referral Clinics. Vermont's Free and Referral Clinics, VFRC, is a statewide association that serves 8 free healthcare clinics. I generally refer to them as our members across the state of Vermont. All services provided at these clinics are free, always. There's no billing insurance, no sliding fee scale, payment plan, bills, and this makes us unique in our healthcare system. There are 2 clinic models that VFRC represents. Free clinics offer medical, dental, and mental health care, plus services such as insurance navigation, case management, and other social services connections. At the free clinics, the clinical care is primarily provided by volunteers. Referral clinics do not provide clinical services. They have insurance navigators on site. They work closely with hospitals to provide support around financial assistance applications. And they're also a really critical resource for patients who need access to free medications. One of our referral clinics provided $500,000 worth of free prescriptions in 2024. Of the referral clinics, 2 are programs that are part of a larger hospital, Mount Ascutney and Gifford, and 1 is a standalone nonprofit. In 2024, our network cared for over 13,000 patients. Over a quarter of those patients were uninsured, 45% were underinsured. Both of those numbers have been rising in the last 2 years. 20% of our patients did not have a primary care provider. Over 40 were at or below 200% of the federal poverty level, so low income. And 10% of our patients are best served in languages other than English. As you can imagine, we work with patients who face significant, often intersecting barriers to care. Some are patients who are unhoused. Some may not have legal status to be in the United States. Other patients have stigmatized employment or gender identities. We serve, as I said, many patients who speak languages other than English, and our members may have patients who use substances. They may have patients who've been labeled non-compliant elsewhere in the healthcare system. And across the board, many are working with patients who have very low incomes. Our primary funding source is a legislative appropriation. It's just over $1.5 million, and it's managed by the Department of Health. This covers just over 50% of our collective operating expenses for our members and for the association. In fiscal year, for fiscal year 26, we are or were seeking level funding. I saw that we have been level funded in the governor's budget, so that's great news. This will be our 3rd year at this level following a generous increase that started in fiscal year 24. As a direct result of that increase 2 years ago, we've been able to invest in staff and infrastructure, including 2 clinics that were able to move to safer locations. It's also allowed us to improve our data collection and allowed for expanded clinical services, including oral health care, increased mobile services, and homeless healthcare outreach. This funding fundamentally allows us to keep our doors open and allows us to be the only place where patients can come for care and be guaranteed to not receive a bill.
Can I interrupt you for just a moment, Olivia?
Yeah, sure.
I'm sorry, I missed something in the translation of the message. Did she say that identify secret locations, I guess, for care? Did I hear that correctly?
Safer.
Okay.
Safer.
Secret.
That would be that'd be interesting. No, safer. 2 were in parts of the Springfield Clinic and the Rutland Clinic were in neighborhoods that had just problems with public safety and violence, and so both were able to move to locations where patients feel more comfortable coming.
Thank you.
No problem. I'm glad. Thanks for clarifying. So I'm sure you've been hearing from everyone about costs and prices. So I just want to take this opportunity to make a plug for our funding as a cost saver. Many of our patients who don't have primary care providers, who don't have insurance or don't have a dentist, would have nowhere else to go for care besides the emergency room. Using this framework in 2024, we estimate that our dental and medical services led to a savings of $5 million in avoided emergency room and hospitalization charges, which for an appropriation of 1.5 million, I feel is a pretty solid return on investment.
You said
It can be.
you said you were funded by the Department of Health and you were level funded this year. Where do you, and that's about 50% of your,
It covers about 50% of our collective operating expenses. Some clinics it's less, some clinics it's a little bit more.
and I may have missed this, but where does your other 50% come from?
You didn't miss it. It's a great question.
Okay.
Some of the clinics have some other grants, but the majority is fundraising. Mostly individual giving, some foundation giving. Many clinics also receive a town appropriation from towns, where patients live that the clinic serves. But yeah, it's a pretty significant gap to make up through other funding streams.
And I think Daisy had a question.
And did you say that you were level funded for the last 3 years?
Our increase was in fiscal year 24. So we had 1.5 million for 24, 1.5 million in 25, and then level funded, if we are funded at that same amount for 26, that would be the third
And
year.
you seemed, I could have misinterpreted, but you seemed really grateful for that, which I find a little bit alarming because we have other providers in the system that, are level funded or about level funded for a very long time. And after a decade, that causes a crisis. So I would just, I'm recognizing that you're grateful for the appropriation, but also recognizing the work that so many people do at a nonprofit to fill that gap in fundraising. And it's grueling work, and your staff deserves not to do that. And I'm guessing that your municipality doesn't have as much money as the state has. So thank you for your work.
Those are great points. And I will say when we were approaching our request in fiscal year 24, we did feel, I forget how you just phrased it, sort of that not quite crisis, but this real pressure from costs rising, expenses rising, and also our patient numbers steadily ticking up. So, I want to say on the one hand, of course, we're grateful. It really has, I can't overstate how that has allowed us to invest in all of the things that I described. And you're right, it's a lot to make up, and I think as things feel more uncertain, it's just worrisome. So here we are.
Olivia, if I could jump in, and I really do appreciate that question, Representative. And we'd be happy to supply the committee with a list of things we would do if we had more funding. I think I think we're just really appreciative of the increase we got a few years ago. It made up for a lot of lost time. I know at my clinic, the People's Health and Wellness Clinic in Barre, this allowed us to expand our oral health care program for the first time in a decade. And we bought new equipment. I expanded the hours of my dental hygienist, and now we're doing extractions for free for our patients for the first time. We saw more than 100 patients last year, and we expect to see even more this year. So that's just one example of the additional funding, things that was made possible with that money.
Is the money that you're appropriated from the Department of Health, is that federal grant funding for them, or is that general fund? Do you know that offhand?
Yeah, so it's our legislative appropriation. It's managed by the Department of Health, and it's considered Medicaid administrative funds. That's the I guess the technical term for it. Half of it is federal, and half of it is state. And then we have a few other grants, a couple CDC grants that are also sort of by way of the Department of Health, that of course are federal.
Thank you.
Yeah.
Woody has a question, actually.
Yes, you talked about hospital financial assistance. Can you discuss that a little bit with us? It must be must take a load off the hospital ERs for having you folks available, obviously. So by contributing monies, it helps their bottom line too, I suppose.
Yeah, yes, I think that's it's an important point. I don't have a number, off the top of my head that we estimate X, Y, or Z is saved because of the work that we're doing with hospital financial assistance. Some clinics work directly with the hospital to sort of help get their patients screened and approved for financial assistance. Some clinics will help patients broadly with sort of paperwork, insurance applications, and also if a patient comes and says, I have this big bill at Dartmouth, I'm not sure what to do. The clinic has staff who say, yep, nope, we know exactly what to do. This is the application and we can support you through that. I don't know if anyone here has seen a hospital financial assistance application, but it's in and of itself, it's a pretty, it can be a taxing bit of paperwork to complete.
And what the state treasury has recently done to help with medical costs, medical debt relief. I suppose that plays a role in your organization as well.
Yes, yeah, absolutely. I would say, I think it can be really easy to focus on all the great work that we're doing. But we exist and we are seeing an increased demand for services because of some of these issues that we're sort of touching on in the wider system. We are very concerned about skyrocketing prices and their effects on insurance premiums. People come to us because they can't pay elsewhere. And 2024, 1/3 of our patients arrived having delayed care due to cost. And so to your point, I just want to say, we are glad to see the attention that's being paid to this issue and, some challenging questions being asked about what's going on.
I'm sorry, we're laughing at the cat, Taylor.
I know, I knew this would happen, so.
That made my day.
That was a good part of the
That's
day.
funny. I thought my cat might come through too.
Can I ask a question about the
Sure.
patient assistance,
Sure.
the, help filling out the application for patient assistance at the hospitals? You mentioned that I think 10% of the population you serve, English is not their primary language.
Correct.
Are you finding that without your help, that the hospitals do not have the resources to be able to assist? I mean, each hospital has a patient assistance program. Do they not have the resources to help people?
I think that's a little bit of a tricky question. I don't want to sort of say that what is happening at the hospitals is not working or is a bad kind of a bad system. What I have heard from our members, particularly at the clinic in Addison County in Middlebury, which serves more than 50% of their patients speak Spanish or other languages from Latin America due to the dairy farm worker community there, that yes, there are some language services at the hospital. They have, because of their patient population, they've invested in bilingual staff, which has been, there's really no comparison between having a staff member who's speaking to you in Spanish versus having to, particularly at a hospital that has a phone-based interpretation system where you have to call up and you have to kind of navigate through this complicated this complicated system and then go through the interpretation process. So for that clinic in particular, having staff on site who can just do it with you has been really important. Dan, tell me, can you add a little bit about your clinic specifically?
Absolutely. So at the People's Health and Wellness Clinic, so we're one of the free and referral clinics. So we both do the navigation side, signing up for health insurance, financial assistance at the hospital, but also free care, both dental hygiene, mental health. We do massage, primary care, acupuncture, chiro, really whatever we can use in terms of volunteers. We are a hybrid model of a small staff, but really about 40 volunteer doctors and nurses who might come in once a month or once a week to treat patients for free. We have 2 clinics each month, specifically just for mostly migrant farm workers, but the non-English speaking patients. And we've had special training with our staff and volunteers, and we usually line these patients up with staff or volunteers that are bilingual in the language being served there. What I hear from these patients and the advocates that work for them is that they come to the free clinics because of the smaller size, the human size of the free clinic as opposed to a hospital, especially right now where they are very worried about immigration enforcement, and that's something we are very worried about, and putting together a plan right now for what happens if there's enforcement at our clinic. But that they're coming to us because we've built this trust and relationship with them and with their community and families. So I think that's the answer to kind of, what role we play in terms of this population.
Thank you.
Yeah, and I would just again, just to add one thing, and again, it's not, I wouldn't say it's criticism, but just feedback that we've heard. And this is again based on the clinic in Addison County, which has worked really closely with Porter, the hospital that's closest to them, that in the past, they had interpretation services. If you got into the hospital and you got to the right window and it said, if you need interpretation services, here's how to say, here's the number to call. But the feedback that they had to give to the hospital was that you need to have signage going into the hospital. You need to have all of your signs translated, because it's not just the ability to hear the application in the language that you speak when you're accessing care at the hospital. It's everything. And so they have found a very receptive partner, if you will, in Porter, kind of trying to understand what they can do to make the experience of patients who speak languages other than English feel like they can really fully access care. They know where to go. They know, who to talk to. So that's another way that the clinics, in addition to providing clinical care and these supports, also sort of interface with the wider system to help patients.
If I may, I did want to talk to this committee about oral health care very briefly. That is a big part of what we do at the People's Health and Wellness Clinic. So in Barre, we are the free clinic for Washington County, plus a few towns in Orange County. We see almost 700 individuals each year, and that's increasing year after year. Our oral health care program is right now we are booking into July right now, but I could get someone in to see a primary care doctor next week at my clinic, but I'm booking into July for the dental hygiene because the need is so huge out there. We are seeing patients who have not seen a dentist or a dental hygienist in their adult lives. Some of them have substance use disorder and have really severely damaged teeth. We hear often from patients, especially before we started the extraction program, that they were pulling their own teeth with pliers at home when it got too bad. And one of the challenges we are running into now is that we have closed that gap and it can do extractions. We can get people out of pain at the clinic. The next challenge is what to put in their mouth once they've had their teeth pulled. A decent pair of dentures, tops and bottom, might cost about $3,600. For all of our patients, this is vastly out of reach financially. And Vermont is one of a handful of states that does not allow Medicaid recipients to use their dental allowance to purchase dentures. And I think this would be an easy fix. The allowance, I believe, is $1,500 a year. That would not buy you both top and bottom, but it would get you really close to one of those two. This would have a dramatic impact on the lives of our patients at People's Health and Wellness Clinic. We've had people who are still wearing masks, not because they're worried about their health, but because they want to hide the state of their mouth from the public. We hear stories of people who are afraid to go to their child's teacher-parent conference because of how they'll be judged because of the state of their mouth. This is a crisis in our communities. And I wanted to raise this issue for this committee. I think there's an easy fix here, at least in terms of the Medicaid program. And I'd be happy to connect anyone with my dental hygienist, and she can tell you exactly what she's seeing every day in Barre with our patients.
Thank you. Thank you for flagging that for us.
So in addition to, as Dan said, the oral health crisis, we're also seeing access to primary care worsening. From 2023 until now, we saw a 17% increase of patients who do not have primary care providers. This is very concerning, particularly if you understand the way that our clinic model has operated in the past, where patients came to us, they got, they filled their medication that they might have needed, they got help with insurance, they maybe got help with financial assistance, getting a bill taken care of at the hospital, and then they got a referral to a primary care practice where they would continue their care from there. And one of the things that we've seen, I'd say certainly recently, but even in the last 4 or 5 years, is that sort of referral pathway from the free clinic network into the primary care network has really been constricted. There's a real backlog. And so that's one of the things that we believe is contributing to our increased number of patients, is that we're also seeing patients for a longer time because we don't have referral partners. I would say it feels like a little bit of an understatement to say that we're concerned with what's happening at the federal level in the context of our work, but also just generally. But I did want to highlight a few things before we're out of time that do directly affect us. Funding freezes, funding cuts, I'm sure I don't have to elaborate about that. Changes to healthcare coverage, premium tax credit subsidies, Medicaid funding would also directly impact us. They affect our ability to both do our work, but they also, and this is one of our major concerns, is that they have the potential to drive more patients to seek care from us. We also, because of our mission and our commitment to marginalized groups, are concerned about attacks on gender-affirming care and on our patients with various immigration statuses and their ability to access the services they need. To close, I do want to recognize and applaud the work that everyone's doing, state government, the legislature, our communities, partner organizations, and more. We feel the impacts of these sort of trends and things that are happening very deeply, and we're worried, particularly for our patients, given how many of them live and work on the margins. But we also do a lot with very little, and we feel really lucky to live in a state where there's so many people who care about everyone living in Vermont. So with that, I hope you keep us in mind as you look for solutions to these challenges, and I appreciate the opportunity to share about our work.
Thank you. Thank you.
Thank you.
Thank you for your work.
Yes.
And I think we need to get to the floor.